So right now we are moving to the surgeon, and fortunately now today we have Dr. Hassan Malik. He is a consultant of a cardiovascular surgeon, and he is a clinical lead for the digestive surgery at the University Hospital of Antrim in UK. Please.
Thank you very much. Okay, thank you very much. I'd like to thank the team to invite me back. So you've heard about chemotherapy and, I guess, interventional oncology, so I'm now going to focus a bit more on surgery, but what I thought is that I'd cover pretty much everything to wrap up the metastatic part of this session. So I'm going to focus on the multimodal treatment of cancer, but obviously mainly on the surgery. This works. Okay, so we know, and this is historical data from the Mayo Clinic, we know that the survival of patients in stage 4 colorectal cancer has improved for the decades. And the question is, why has this been? Is this just better chemotherapy, or is there something else going on there? And I suspect that this is better MDT tumor board working, looking at all the options that we have available for these patients. I want to give you a few facts, and we can always debate about whether these are accurate or not. The first thing is that the pathological response to chemotherapy does impact survival, and this is data from MD Anderson, which essentially shows that as the response to chemotherapy improves, the survival of patients increases. So it's a very good biomarker for those patients who will do well in the long term. So that's important to know. I think the other thing to accept, I guess, is that as response to chemotherapy, so this is radiological response to chemotherapy, increases, then the surgeons can make more of these patients potentially operable. And this is a meta-analysis that we did with Gunnar Falbrecht, who's a German oncologist who led on the CELIN study. And essentially what you can see on the x-axis is the response to chemotherapy, and on the y-axis the resection rates. Now you can split this into two actual groups. The bottom group in red are studies where essentially there was no tumor board, no functioning tumor board, and no one thinking about liver surgery as an endpoint. And not surprisingly, despite quite remarkable response rates, people didn't get an operation. Whereas in the other blue cohort, you did find that if you were thinking about surgery, a functioning tumor board, and I think that's the message I want to send out today, then people thought about surgery and people got surgery. And we know that there's a lot of regimens. You've had this morning, and essentially now we can get response rates in the high 60s, 70s, and that should translate into a secondary resection rate of about 30 to 40%. The next thing I'm going to say is liver surgery works. Okay, now we do not have a randomized controlled trial comparing liver resection with palliative chemotherapy. Similarly, I have to say we don't have a randomized study comparing jumping out of an airplane with or without a parachute. Okay, all we have is phase 4 data in tens of thousands of people who are alive today. Okay, so this is data from the NHS, and this is the survival over a 5-year period of all patients with colon cancer, and it's over 100,000 patients here. This is your stage 3 node positive disease survival, which is about 40-45%, and this is unfortunately the reality of patients with metastatic colorectal cancer. The median survival is 12 months. Okay, you see some fantastic results in clinical trials where the median survival is pushed out to 24 to 30 months, but that's a very selective population you can get into the clinical trial. This is the reality out there in the population. But if you take that metastatic disease, and this is mainly liver resection, and you chop it out, then the 5-year survival equates to stage 3 disease. So I think that is quite important data, and if you can get patients to 5 years, we can certainly get to 10 years, and this is data from the Liver Met Survey, which is now in excess of 20,000 patients registered, and the 10-year survival is about a third. However, there is a problem. Now, in the UK healthcare system, it's very regulated, and we collect a lot of data. But this shows a variation in liver resection rates across the country. Now, assuming that the incidence of colon cancer is the same in the country and the incidence of metastatic disease is the same, then there's a tenfold variation in the UK in access to getting a liver operation for that metastatic disease. This is where we were in Liverpool, and there's a lot of missing patients out there. Okay. Now, this study we undertook, and this really has changed NICE guidance. This was in our network, and you can see which we are a very highly performing network in the UK. These were patients with liver-limited disease who had never been referred to our tumour board. Okay? But they were all fit enough for treatment with systemic chemotherapy, and they all got palliative chemotherapy. So the local colorectal tumour board, with oncologists and colorectal surgeons, did not feel that these patients were fit or appropriate for consideration of liver resection, so they were all palliative. We reviewed those scans, and in 2/3 of cases, we would have done things differently. And we thought this is a bit odd, so we sent the data to the chaps in MD Anderson, to Renia Dam in Paris, and other colleagues across the country, and they all agreed. Okay, so what's going on there? Well, we know from this attempt at a systematic review that there's a number of variables that predict for poorer outcome after liver resection. Okay, and you can see the hazard ratios up there. Okay, but the fact is that these are all relative, contraindication. Not one in itself is an absolute contraindication to being considered for liver resection. So this is now CG131. So if you want to know about colorectal cancer from diagnosis to death, this is the NICE guidance that came out a few years ago, and it basically covers everything. And it takes a pretty robust evidence-based approach, and it came up with 8 key quality standards. And the main change in the UK was this quality standard 6, which says that if you have liver-limited disease picked up on a CT scan and you're fit enough for treatment, then you should have those scans and those images reviewed in the tumour board. And this is the compatibility tumour board. So about liver surgery. Well, this is what we used to do. We looked at the liver, we looked at the types of lesions in the liver, and basically we were focused on unilobar disease, less than 4 mets, etc. And about 10% of our patients were initially operable. Now what we're trying to do is to essentially leave enough viable liver so that the patient can survive their operation. So simple as that. And just by changing that mindset, about 20% of patients are resectable at presentation, and we know with chemotherapy we can increase that. So we were initially focused on what you took out of the liver, and now what we're doing is looking at what you're leaving behind. Okay? And okay, so this is a few pictures of livers, and what can you do? Well, if you've got several mets in the liver, the options you've got is to either do a right hepatectomy, or you can do non-anatomical metastectomies. But if you did it right, and the patient developed an awkward recurrence in the left, then what options do you have surgically? But if you did a metastectomy, then you still have the option in the future of doing the right. Okay. And we know that there's no difference between these two approaches in terms of survival. So in my mindset, what we tend to do is think about the next hepatectomy and the hepatectomy after that. We're often doing parenchymal preserving surgery, and this is what Renia Dam talked about almost 10 years ago. What about more extensive disease? Well, this is the type of disease we often do see with multiple bilobar metastases. What are the surgical options here? What you can do is this concept of two-stage hepatectomy. So you clear half the liver, and if the primary tumour is in situ, you can often deal with that at the same time. Then you do a portal vein embolization, okay? And this causes hypertrophy of the future remnant liver, and you come back and then you complete the resection in about 6 weeks' time. So this is, again, an old picture, but essentially it shows that you can grow the liver. Okay? But I do agree that radioembolization to cause future hypertrophy is an interesting approach. Unfortunately, the UK is not funded for that specific indication. So this is survival again from the liver met survey. If you do the two-stage approach, obviously they do worse. I mean, these patients have more extensive disease. Not surprisingly, they do worse. You still get 5 and 10 years survival with this approach. The problem with this is that about a quarter of these patients will never come to resection, and that's because they progress. Okay. So that led to an interest in this technique, which is the ALPS approach. So this is, I have to say, some of the best and the worst of surgery and surgeons. This was an accident. Okay, it was presented as a poster in the EHPBA meeting in South Africa, and essentially it involved a surgeon in Germany attempting a liver resection. He felt that after having split the liver and divided the portal vein on the right, there wasn't enough liver for the patient to survive, so he closed the patient up. And he did a scan a week later, and the left liver had grown massively, and he came back and finished the job. And he presented a number of cases, so it was an accident, and that's often the case in surgical developments, really. But this is now being taken up by a whole bunch of different groups, and they are starting to present their data. Globally, the numbers of cases done are quite small. Okay. What you do see, and this is from a large multi-center French series, that the liver hypertrophy is fantastic, but the big concerns are related to morbidity and mortality. Now, you could probably see down there, but the mortality rate in that series, and these are experts doing this, is about 12%. Okay, so please keep that in your mind as the talk goes on. So the main concerns about this technique are high morbidity and mortality. There's no survival data published, long-term survival data. And the groups that are doing this are planning to do a randomized study comparing ALPS versus a two-stage appendectomy. So at the moment, this is experimental. Okay. In terms of the more extended liver resections, we can resect up to 75% of the liver. These techniques can be applied for XCC, cholangiocarcinoma, various tumour types, as well as colorectal. What I'm talking about are tumours that involve the inflow, which is the hepatic artery, portal vein, bile ducts, the outflow, which is the hepatic veins and the vena cava, often, unfortunately, both. In terms of inflow, this is a intrahepatic cholangiocarcinoma involving the left liver, replacing part of the right, but also involving the right posterior ducts and the vessels there. And we did a left trisectionectomy, had to resect the bile duct, and then do a real wide reconstruction. So that can be done. This is a perihilar cholangiocarcinoma with an atrophied right liver. Technically, you would argue inoperable. It's a type 4 tumour with a tumour that's encasing the left portal vein, having taken out the right portal vein. But then you can do a portal vein resection and reconstruction with a right trisectionectomy. So these techniques can be used mainly in primary liver tumours, but often, or sometimes in colon cancer, it can involve pedicle as well. This is HCC, large tumour in a fibrotic liver, with tumour thrombus within the portal vein. So this would not be a patient due to either size or microvascular involvement of the portal vein, would be considered for transplantation. You can do a thrombectomy and then hepatectomy. Outflow issues are the ones that we as surgeons worry about. Essentially, these tumours are involving the hepatic veins, the vena cava. Often we do a right-sided resection due to the anatomical location. We can often cross-clamp below the left hepatic vein, above the renal veins, and just do a resection with a primary closure. We've done quite a few of these cases in Liverpool. If you've got a larger defect, then you can put in a bovine pericardial patch, and this is an example. The vena cava is open there, and then you use this patch to just close the defect, and it takes stitches quite nicely. When you have massive and monstrous tumours like this, then you do have to replace the vena cava. We did set this up for a vena bypass, but we didn't need to use it. So all these techniques are possible to deal with this type of disease. And you can often do multivisceral resections. This is a tumour growing up into the chest, into the lung. And we did a diaphragm and lung resection to deal with that. What do we do? I mean, how do you consider what operation you're going to do? I think you have to, as a surgeon, look at technical resectability, and that's based on your imaging and what you be able to take on. I think as surgical oncologists, you also need to look at, is it sensible to take on this disease? Okay, is it going to make any difference? But the other thing you have to be honest about with yourself is whether it's safe to do this in your institution, in your hands. Okay, you can see this, in a meeting, but it may not be sensible or safe to go away and do this type of procedure tomorrow yourself. Okay, and then you can risk stratify patients and then have that discussion with the patient and the family. I'm going to briefly touch on local regional treatments. These are all the options that are there. You've had some of these already. These are all the things that we can use to treat liver metastases. Hepatic infusional chemotherapy, kind of popularised by Sloan Kettering, has gone out of favour. There's been a Cochrane review, there's been a number of reviews, and it hasn't really shown any benefit in terms of long-term survival. External beam radiotherapy, again, quite interesting technique used for a number of different tumours. In terms of liver, it's been used for a number of things from HCC to cholangiocarcinoma. Numbers of cases are quite small. Essentially, the local control seems to be reasonable, but there isn't data in terms of long-term survival. So at the moment, it's not recommended by NICE. Debiri is an interesting approach. This is chemoembolization for the liver, and these are microspheres that you insert into the liver through the hepatic artery. It's initially been used in third-line settings, and this is an Italian paper showing interesting response rates in chemorefractory patients. In terms of surgery, we did a trial looking at Debiri as a safety study, and what we found is that these were the response rates of the tumour after they've been resected. So if you look at that and compare that to systemic chemotherapy, what you find is there's quite interesting complete and major responses to this treatment. So it's an interesting concept. Okay, this is a patient who we were planning to treat. We taste the lesion we saw. We identified a new lesion in laparotomy and untreated metastasis to that viable tumour, not surprisingly. You can see the extensive fibrosis and necrosis in the treated metastasis. The one thing to remember about this technique is, unlike the taste for HCC, irinotecan is a prodrug, so it needs to be activated. So do you do a very selective segmental embolization or a more lobar embolization? And what we published is that it's the hepatocytes that activate the irinotecan, so you need to be a lobar embolized flush rather than more selective. But the tumour isn't able to activate irinotecan in intestine 38. So where does Debiri lie? Well, data from the States, from Rob Martin's group, shows that with systemic chemotherapeutic agents is probably as effective as triplet chemotherapy, but perhaps with less side effects than triplets. You've heard about Sortex. There's a number of small studies out there. You've heard about the data from Surflox. We're waiting for Foxfire Global, which should come out in ASCO next year. At the moment, based on all the evidence to date, in the UK, it's recommended in the third line setting. So if they fail 2 lines of chemotherapy and it's liver dominant disease, then they will get access to this. Ablative options, there's a number of things that you can use, but essentially they can destroy the tumour. This is important. This is the first evidence that any form of local regional treatment makes a difference to survival. So this is the clock study. This is patients who were inoperable and randomized to radiofrequency ablation of the liver metastases. And it took 20 years to get this data, but ultimately there was a survival benefit of treating the liver above and beyond the palliative chemotherapy. But you can also combine ablation with surgery, and this is a patient of mine who had multiple biliver metastases and a centrally placed tumour as well. And we did left hepatectomy, resected all other disease around the right liver, and then ablated the tumour deep within the liver. I mean, the ALPS concept cannot deal with that type of disease. When we looked at this, and we compared our data with a number of other international centres, we found that overall survival was about 40% at 5 years. But the key thing here is that the median number of tumours is 5, so this is really the worst end of the spectrum in terms of disease. And this is a safe operation. We've not had one death in Liverpool by this approach, compared to the ALPS with 12% mortality. Okay, and when you compare this technique to two-stage hepatectomy, the outcomes are comparable. Reversible electroporation is a new technique, the nanoknife. This uses high intensity electric field to kill the tumour, disrupt the cell membrane, and it's interesting, it's very operator dependent. This is a case that we had whereby you had disease involving the left and the middle hepatic veins. You needed a kind of left hepatectomy, but they also had disease involving the right hepatic vein. So we treated the right lesion with that thing's gone, so let's close that. With IRE, and then did the left hepatectomy. So I'm just wrapping up now. I think, you know, we talk about personalized medicine with chemotherapy, and I think with interventional oncology procedures, we're looking at that as well. We're trying to, you know, tailor our treatment options for the patient, and that's where the tumour board is crucial. And these are all the options that you got here to manage stage 4 disease. How do you deal with the primary? You can hear a bit about radiotherapy for the primary. The biggest problem we find is locally advanced rectal cancer with advanced liver metastases. How do you manage that patient? There's about 2.5 million different options when you look at all of that. Okay, but when you put it all together, you know, this was the survival of stage 4 disease in the UK in 2000. Okay, 3% 5-year survival. Okay, 10 years later, the survival with palliative chemotherapy and more lines of chemotherapy in Liverpool is 15%. This is the palliative group who never have an operation. About half the patients who come to our tumour board will ultimately have surgery. Okay, so when you add the impact of that, the survival for all patients in stage 4 disease in Liverpool was 30%, and that's a massive increase over 10 years. Thank you very much.
Thank you, Professor Dr. Malik. And now we are going to our next speaker, Professor Dr. Mohammed Salim. He's going to give us a presentation on choice of treatment in stage 2 colorectal cancer.
I'm a GI oncologist. My main focus is colorectal cancer. I work in Georgetown University in the Novartis Cancer Center in Washington, D.C. I have to say, I think now it's about half the time of my life I spend here in Egypt, and half as a second half I spend in America or the States. And in my way here on the plane last night, I actually had a lot of reflection on that. One of them is that I was very happy to be here. It was very exciting for me. And I thought about it. I thought it's more like a marriage. So frankly, I'm very happy in the United States. I think it's a great country. I really enjoy being there. I think it gave me a lot. It's exactly like my wife. But I think Egypt is like my mother. United States gave me success, but without my mother, I would have no existence. So it's really very close to me in my heart today to be here and present among you. I know the chairman usually like us to be on time, so we'll try to move on. This is my disclosure, but actually it has nothing to do with the talk today. And I promise I will be on time, but there's a few things I would like to show first. Usually when it's too dark, people tend to fall asleep, so if you can, please turn the light on, because even the speaker might fall asleep. But also one of the things I reflected on the plane was this. The logo for the conference. And I thought it was a very, very interesting logo. And the reason behind that, because I think it's a succession. And any organization to be successful and have an impact and be like a changer team, they have to have a mission and vision. And I thought this was the message here, saying drawing the plan for the cure. And if we have that vision, I think we can change things. I think that the legacy will leave, and I see this organization is going to get there. And I think That's okay. I'm fine. So I think this vision is important. So if we can cure cancer, that's a legacy we'll have one day. And that's also the obligation all of us have. All of you taking care of cancer, but I want you to raise your hand. Not as a physician, as a person. Do you know a loved one, family member, brother or sister, son or daughter, had cancer? Just raise your hand. Any one of you had a co-worker or a friend or a neighbor had cancer? Look around you. Is this why you are here today? We're not here just because this is a job. This our opportunity to try to get the legacy and move this to the next step. When patient comes to my clinic in DC, they don't come for radiation or surgery or for anything else. They actually come to be cured. And in fact, 2 years ago in the cover of Type magazine, this was the topic, how can cure cancer? And coming from Egypt, and everybody like soccer, it's a team sport. We know no one person in the team can just win. Everybody has worked very hard and have to help each other to win and score. And guess who's gonna win at the end? Our patient will win at the end, and therefore will keep our loved one around. So in his famous book, The Art of War, Sun Tzu said, if you wanna know your enemy, know yourself, and then you fear nothing. And I think that's why we're here today. So back to the talk. My job today was to talk about stage 2 colon cancer. And I thought actually maybe a better question is to treat or not to treat. Most of us see those patients in the clinic and we struggle, should we treat them or should not? So let me give you a quick statistics. In the United States, about 140,000 people get diagnosed with colon cancer. 50,000 of them will die every year. Do the math, that means every single day, more than 100 patients die. 10 years, 500,000 people die. I'm not gonna have the time to go through this today, but World War II, we didn't lose that many patients to cancer. Every year, we lose 7 million people for cancer around the globe. This is not just a United States problem, it's worldwide problem, all over the nation, all over the planet. And of course, the favorite cancer among everybody is a breast cancer. I live in DC, a couple blocks from, I work a couple blocks from the White House. That's the only ribbon that was hanging down from the White House. Of course, that's a breast cancer ribbon. I have to ask, if we change our ribbon to brown, which is currently blue, we might get a chance. So, when we see our patients in the clinic, they come either in different flavors, stage 1, 2, 3, or 4. And here you see about 20% of patients will present for stage 4, and the survival is dismal. But it depends on how you look at things. You can look at cup half empty or half full. That means, yes, 20% of patients will do bad, but you heard from Dr. Schoen today that we do better and better now, trying to come up with more therapy and increase survival from 6 months a few years ago to now almost 3 months. But this also, if you see the cup as half full, giving you a huge opportunity to try to help 80% of the patient. And hopefully you achieve what we need to do, curing them. The problem is, it's not easy and not straightforward. So, for example, you see here, the stage 2 cancer patient, they really not the same thing. They do different among each of them. Some of them do very good and some do not much. And even though when it was stage 3, they're supposed to be worse, but some of stage 2 actually do worse than stage 3. Therefore, adjuvant therapy is not a straightforward question in this setting. So, I also run my fellowship program. So when I teach my fellows about adjuvant therapy, there is basic principles we need to understand. One, not everything works in the metastatic setting or advanced setting actually work in the adjuvant setting. And colorectal is a perfect example of this. Fulfiri, capacitance, fluximab work very nicely in the metastatic settings. They don't work in the adjuvant setting because of this. So the hypothesis is which saying you have the receptors here, but then those cells which express the receptor, they actually they go under the conformation and they become musical phenotypes, and then they metastasize, and therefore your therapy that works on the receptor here wouldn't work in the second setting here. But then, like Wall Street Syndrome, you have also in the adjuvant setting, you have to look at the return and the risk. When you say about adjuvant, you want to see how much benefit you give your patient and how much risk you're gonna put them through. And it's really very subjective. So here, if you look at this picture, you have an old woman with her mouth and nose, but you also can see a young woman here, her eyes and her ear. So 2% to me might be totally different in value of 2% to you. And I have to say that's a discussion you have to see and take place with your patient. The third rule is usually the recurrence in colorectal cancer happens in the first 3 years. So as a GI oncologist, what do we use? 5-FU. And it's not a curse, this is actually a drug. 5-FU has been around for a long time now. Initially we thought like it can be infusion, it can be bolus and then infusion over how many hours. At the end of the day, I think we finally found out what is the best day to give 5-FU. And then we came up with capecitabine, and we were able to see that capecitabine is non-inferior, perhaps even better, but from here I have to say actually it's non-inferior to 5-FU. Then the question was, can we add or build on that? Every GI oncologist is very familiar with that study. That's a mosaic study that was published in New England Journal of Medicine in 2004. They randomized about 2,000 patients. 40% of them had stage 2, 60% of them had stage 3 to receive, after surgery, to receive what at that time used to be the standard of care, which is 5-FU versus FOLFOX, which is 5-FU plus oxaliplatin. Primary endpoint was disease-free survival, and actually the study was positive. It was about 5%, as you see here, improvement. The study, after further follow-up that was published in 2009 GCO, actually showed the survival remained positive. But when we looked closely, we found that most of the benefit actually is driven from stage 3 colon cancer, not really stage 2. Even stage 2, it didn't reach statistical significance. Yet, which is the gold standard in what we do, the survival was not positive in stage 2, but was positive for stage 3. So this raises a question, did anybody or did any patient with stage 2 colon cancer benefit from having this adjuvant therapy? It didn't reach statistical significance, but here came the concept of high risk stage 2, that specific group of patients who might benefit from this therapy. And the definition in the mosaic study, and I warn you, this is not every study, there's a mosaic study, was high risk was T4, obstruction, lymph node invasion, or less than the lymph node dissected. Why is that important? Because what we do is very powerful, it kills cancer, but also can have significant side effect. This just show you that at 4 years, patients still have neuropathy. Some of them, they couldn't even tie their shoes. So that's something you don't want them to experience later on. Why is stage 2 an issue? Because sometimes people cite this study, the COSARA study, quite simple and reliable. This was done mainly in England. United Kingdom, showing that there is some benefit when you give adjuvant therapy for stage 2, but this 2.1. Again, I'm not going to say 2.9 is good or bad or high or low, it needs a discussion, but you need also to know that at that time, the median lymph node dissection was about 6 lymph nodes. So some people wonder perhaps this benefit actually was for stage 3 who were underdiagnosed or under stage at that time. So the question comes up, should every patient with stage 2 colon cancer receive adjuvant therapy? That's how we used to look at stage 2 colon cancer, that everybody is the same. But we start to know, no, perhaps not. There are some people with high risk features that may actually benefit from the adjuvant therapy. Some people with low risk disease that may not need anything, and some people may be in between. Even though now, as you heard Dr. Truman in the morning, we think each colon cancer is the same. If it's from the right side, it's different from the left side. So how we figure this? If you follow American movie, I think we need a Harry Potter sorting hat. So we need something to tell us who actually surgery is enough for them, who surgery not really enough but might get cured by 5FU, and who will need 5FU plus oxaliplatin, and who are those unlucky people who actually whatever you do, you're never going to cure them, and they are destined to relapse. We start to look more about the risk features. So we start to study pathological risk features and molecular risk features until actually a couple months ago, a new study came looking at the same question, trying to give some answer. Multiple studies were done, so we did the multivariable analysis trying to understand who actually high risk, and very much consistent across the board that every time we see T4, they actually do worse. So T4 is something you need to pay closer attention to and perhaps offer them treatment. And also the same thing was seen in the COSAR studies that T4 were the highest risk. Microsatellites stable were actually the lowest risk, and then you have in between. The same finding in informant table. So most of us as a GI-oncologists now, we actually think that T4 is a more aggressive tumor, and perhaps we actually consider strongly doing chemotherapy. If you have less than 10 lymph node, that's also a bad prognostic feature, and you should do it. So I want to spend 1 or 2 minutes talking about mismatch repair deficiency, because actually it's a very important topic now, and I think we'll be using even in the metastatic setting, and also it's confusing, so I'm hoping to shed some light on it. In general, most of the colon cancer are sporadic cases. Henry Lynch, many years ago, who found the subgroup of patients, which about 5% named after him, they had that. And you have a family history of about 30%. So what microsatellite is stable? It's actually, those are the DNA that control or police your cells against any defect and repair the error that happened in DNA. Any mutation in those genes, especially in those 5s, will result in insufficient protein. So if you have a deficiency, you can call it either mismatch repair deficiency, or you can call it microsatellite unstable tumor. Both means the same thing. They are associated not with only colon cancer, actually associated with different other malignancies. And pay attention to this one, which is interesting, that not everyone is equal. So if you have MLH1, your risk of having colon cancer might be lower or higher than if you have other ones. So not all of them have the same effect. So that's a 5% hereditary, that's the germline mutation. But there is other group, about 15% or so, in colon cancer is sporadic, so it has nothing to do with the germline mutation. They actually have the same phenotype, which is a microsatellite. and its instability. And it has to do with the hypermethylation of the genes here. It ends up in the same way, same result, but actually the reason is different. We know now that microcephalic stable tumor are about 15% sporadic and 5% germline. They are usually right-sided, female. They usually have a better prognosis, and although the tumor is poorly differentiated, yet they actually do very well. By the way, that's a different story from the metastatic setting. And by the way, as you heard Dr. Shum in the morning, immunotherapy works in the metastatic setting very well for this patient. So I urge you to actually check that feature on your patient even when you see them. We also learned that if you have microcephalic stable tumor and you give 5-FU, it helps. This is the upper curve here. But if you have microcephalic unstable tumor, two features which are very interesting. One, they do very well, the top curve here. But worse, which no GI oncology, in oncology want to do, is that when you treat them, actually they do worse. So we don't like or advise to give your microcephalic unstable patient, tumor patient, 5-FU. This is not FOLFOX, by the way. FOLFOX is a different story. We think FOLFOX actually works. Dan Sargent from Mayo Clinic also looked at the same thing, and as you see here, they do very well, both disease-free survival or overall survival, and if you give them 5-FU, they actually do worse. You can check it by immunohistochemistry stain or also PCR. But the problem is, again, what really you have is about 18% of patient microcephalic status unstable, and T4 is about 11% of patients. So that leaves us with majority of patients really not assigned for. Therefore, sometimes we can use oncotype score. There is 2 points I want to make here before I finish. Oncotype score is nice because it gives you an idea, but yet actually it doesn't tell you if the patient will actually respond to chemotherapy or not. So it's prognostic, but not predictive, not the breast cancer story, which is totally different story. And as I mentioned a few months ago in New England, this was published showing that perhaps the tumor, if it doesn't have CD expression, they actually do worse. And for those people, you might actually need to add chemotherapy. This is a recommendation from ASCO and from NCC guideline, very much saying that you just have to individualize patient and do your treatment accordingly. So this thing, the last slide. So very much the way we think about colon cancer in stage 3, you actually should give them adjuvant therapy. If you have elderly patient, maybe you can just get away with omitting oxaliplatin. If you are stage 2, if you are a high risk, T4 or lymph node less than 12, you're high risk, you should give them 5-FU or gemcitabine. If you are a low risk, you actually watch lymph node therapy. And if you are in intermediate, maybe you can use score. So choices for treatment for stage 2 colon cancer, and I have to admit this is my most favorite slide for cover reason. Who's that? Who's this? Very usual. Who's that? Omar Sharif. So Omar Sharif was a very sexy man in 1960s. That's how 5-FU used to be. Now, he's a very handsome man, but not the same. That's the way I actually look at 5-FU. Yes, it's a very good drug for us, but maybe we need to do better. So we spicy thing a little bit with oxaliplatin, and we wonder who really can get benefit from 5-FU and who get oxaliplatin. So you have to look at your patient differently, because some of them actually are very good with microcephalic unstable. They don't need anything. Of course, they don't need any help, and perhaps doing 5-FU will actually hurt them. But then maybe FOLFOX work for those people. This T4, definitely you need for FOX. And then you have the intermediate risk people who are not sure really what to do with them. Just to conclude, Winston Churchill said in his one of his famous speech in World War II, this I'm not going to read for you, I think it's very, very well known. But I think today we gather here to say this together, if I may. And please read it with me. Actually, I would like to hear it here in my home country. Go ahead. We shall defend our lives. We shall defend our lives. Together we shall defeat cancer. Together we shall win. Whatever the cost may be, we shall fight for the cure. We shall never surrender. We will win. Thank you very much.
Thank you, Dr. Salim, for your presentation. Now we'll move to Professor Christopher Crane. The title of the talk is Rectal Cancer, Short versus Long Course, Radiotherapy, Techniques and Outcomes.
Thank you very much. I feel very honored to be here, and I'd like to thank the organizing committee for inviting me. I've always wanted to come to Egypt. This is my first time here, and I'm very excited to be here. Thank you. So the topic today is about short versus long course radiation, which has been somewhat of a controversy internationally for a long time now. But there are randomized trials that we can talk about and to help us understand these two options. So even though we do have randomized data that I'll show a little bit later, the short course radiation still has not been widely adopted in the United States. I'll show you why that probably it should be more adopted in the States. I know it's used more commonly in Europe and other places. It certainly has been established as a valid option in randomized trials with survival improvement, similar to what we've seen in postoperative long course chemoradiation. The concerns have been centered around toxicity, both mainly I think long-term toxicity risks that come with the larger doses per day of radiation, which can lead to some irreversible side effects if the tolerances are exceeded. So in order to minimize those toxicities, we'll talk about some techniques that can be used, and it simply just means avoiding treating those structures if you can. So the trial that started all of this or established the role of short course radiation was the Swedish rectal trial, which was short course radiation, 5 Gray times 5, which is still the regimen that is used, followed by standard surgery, not a mesorectal excision, but a blunt dissection surgery versus surgery alone. And this was originally published back in the late 90s, mid to late 90s. This is the updated results that show an improvement in local regional, a reduction in local regional recurrence from 26 to 9%. And that translated to a survival benefit. So this really established short course radiation as a valid option. As you can see at the bottom of this slide, no positive patients benefited much more. Again, this is blunt dissection surgery, but with surgery alone, 43% pelvic failure. That was reduced down to 23%. And importantly, and this is an important thing for selection, one fact that I use is that the tumors that were high in the pelvis, 10 centimeters or more from the anal verge, did not benefit, even in spite of the fact that there was a huge improvement in local tumor control overall. The ones that were high in the pelvis did not benefit from the use of radiation. And that was even with essentially blunt dissection surgery, not the better surgical techniques that are more common today. The trial that followed that was a Dutch TME trial, which was a notable trial because it had excellent surgical quality control on it. Surgeons had to be certified in mesorectal excision before participating, which is an excellent example of what should be done if possible in trials that include complex surgeries. And that was mesorectal excision because the argument was with better quality surgery, we still don't need radiation. In one arm, and then the other arm, preoperative short course radiation followed by immediate surgery in about 1 week after the radiation. And again, this updated results, there was an improvement in local regional, a reduction of local regional failure from 11 to 5% in 10 years. That was statistically significant, but no survival benefit was seen. So with better quality surgery, the local recurrence rates were much lower, 11%, and could be reduced in half. And you could argue about the clinical significance of that for all patients, certainly. But I think if you, they had a pre-planned subset analysis in this large trial, and the group of patients who had margin negative, circumferential margin negative, did have a statistically significant benefit in local control, but again, single-digit failures with surgery alone. So you can argue about the clinical significance of that. But the node-positive patients who had margins negative, again, this node-positive factor is an important prognostic factor that can predict for the benefit of radiation. The local regional recurrence rate was a little bit higher, 17% with surgery alone, reduced to 5% with the use of radiation, and there was a survival benefit of improved from 40% to 50% with the use of radiation. So I use this data to argue that in patients where we know the nodes are positive, even with the best quality surgery, radiation improves survival. Now, the concern also that has been raised is about the late side effects of these high doses per fraction. And fecal incontinence is a concern, and that's a concern that I have about, and probably why clinicians have not wanted to use these large doses per fraction for the low rectal tumors. In addition to the lack of proven sphincter preservation benefit at this point, is that radiation causes a reduction in sensation of the anal canal, and if the whole rectum is removed, there's also urgency, and so it can lead to fecal incontinence. And certainly we want to minimize that, and it makes sense that you would want to use smaller radiation doses in those patients to minimize that risk and maximize the bowel function over time. As you can see from this graph, there's statistically significant reduction in bowel function, if you will, with regard to fecal incontinence with the use of radiation compared to surgery alone. This is not a comparison between short and long course. The MRC-CO7 trial from the UK was another trial with a similar randomization that compared preoperative short course radiation to followed by surgery versus surgery alone. Again, showed very similar results to the Dutch TME trial. Improvement in disease-free survival due to the fact that it was such a large trial, but the absolute differences were very small. And again, there's very interesting quality patient-reported outcomes data from this trial. Overall, there was not a reported difference in side effects in the top part of this graph. But with regard to fecal incontinence, there was a difference. And you can see from the line, these lines right here, that there was a difference overall in fecal incontinence, but it was generally in the mild. So the way they broke it down was a little, quite a bit, and very much. And the difference is really in the a little. So whatever that means, I usually like to ask patients how many times a month they're having accidental bowel movements. And so this is the severe, quite a bit, and very much, and there weren't much differences there. But this is everything with fecal incontinence. So most of the differences were in the milder symptoms. So let's move on to the randomized trials, short versus long course. There are 3 trials to talk about. One's the Polish trial, The one is a trans-Tasman group trial from Australia and New Zealand. And the third is the Stockholm 3 trial that looked at short versus long course radiation. The Polish trial was a 316 patient trial randomizing short versus long course radiation, followed by surgery. So again, just all preoperative therapy. There was an increase in path response, as you would expect, because the path response increases with time to surgery, and short course radiation typically has always been immediate surgery. So the tumors shrunk more with the longer course radiation, but that was due to the longer interval. The surgeons really didn't change their mind about the surgery they were going to do, even though they documented the tumors were 50% smaller or whatever it was during after chemoradiation. The surgeons didn't really change their mind, so sphincter preservation was not effective. The other thing that it was flawed in this analysis is they included people that were not at risk for having an APR in their sphincter preservation analysis. They included all patients. It should only include a subset of patients with low rectal cancer to see if there was a difference in that. But there was no difference, is what they reported. And there was no difference in local control or overall survival. So that's the important thing, the most important endpoint. Those are the most important endpoints. And from their analysis, no difference in quality of life or anal or rectal sexual function. The TROG trial is a similar size trial with 326 patients, randomizing similar randomization, short course versus long course radiation, that power to detect a 15 versus 15% local regional pelvic control difference, and basically showed no local control, disease-free or overall survival differences, or any grade 3 or 4 late toxicities, so physician-reported toxicities. The Stockholm 3 trial hasn't reported its efficacy results, but this is a 3-arm study, adding an arm to allow a longer interval between surgery and between radiation and surgery to see if they could give the tumor time to shrink so that the sphincter preservation endpoint could be improved. And so this an interim analysis has been reported just about the toxicity, and overall the surgical complications were not any different between the 3 arms. But one interesting thing emerged, and I think that I understand why this happened, is that if the patients had immediate surgery, the postoperative complications were very similar to if they had delayed surgery. So the delayed surgery could be either with short or long course. But if for something happened and they had surgery later than expected than the 1-week interval, whether it was logistic or some problems with their health or what have you, then there was an increase in complications. And this is probably due to the fact that that's when the side effects of the short course radiation would start appearing, is in the 2nd and 3rd and 4th week. So they're operating at the time when the patient's recovering from acute toxicity from radiation. So the bottom line from this is it appears that you can use either a short interval or a normal interval, and the perioperative complications will be the same, but not you shouldn't do anything in between. So I think in summary, short course radiation is effective, it's safe. The late effects are not clearly a concern except for maybe mild differences in fecal incontinence. It's cost effective and convenient. I think that toxicity of the anal canal and possibly other long-term effects still have to be monitored, and we would wait for the long-term effects that'll be reported from the Stockholm 3 trial to make some more determinations. And we still don't know whether sphincter preservation will be as effective for low rectal cancer with the short course radiation followed by a long interval in surgery. So, but I think, in my opinion, short course radiation is underutilized in the States and certainly can be considered in most patients. We generally use it for patients who have metastatic rectal cancer where we don't want to use too much time because that systemic therapies are more important. I'll just touch on a few things Since many of you may not be aware of radiation techniques, some basic radiation techniques, we use immobilization devices. One of the things that we use for rectal cancer is a belly board. So the patient lies on this device, and their lower abdomen falls into this open tabletop, so that the small bowel is displaced from the radiation field. And this is just an immobilization bag that keeps the patient still during the treatment. These aren't used together, but it's just another way of immobilization. This is a head frame for stereotactic treatment of the brain, and this is a mesh used for head and neck cancer patient, again, to immobilize the patient. So this is just a diagram showing what the belly board does. It removes the small bowel from the pelvis as long as it's not fixed in the pelvis. So our first step is we get most of the time a CT simulation these days. The patient's positioned on the table, and we get a CT scan, and then we do the radiation computer planning. We design beams that can be a variety of techniques, and with older 2D techniques and with 3D techniques, that's simply using lead blocks or automated blocks within the treatment in order to block the beam and shape the beam. The types of radiation modalities we have is the older cobalt-60, which the only disadvantage of cobalt-60 is that it's a low energy, so it doesn't penetrate. So there's higher doses that are given towards the surface. But the most commonly used radiation is linear accelerators, as you see here, where we use high energy photons or X-rays and or electrons. Also, protons are very common now in the United States. Many centers are opening, and they have different physical characteristics. It's not going to replace photons, but it'll be something that's used to complement our current treatment approaches. The standard radiation treatment is just simply 3 beams, 1 from the back and 2 from the sides, that treats the regional lymph nodes and the primary rectal tumor, sparing the anal canal when possible, sparing the intestine when possible. Here's an example of a 3D plan. These lines that you see here are the doses of radiation that enables us to tell how much radiation is going to which of the organs. And so technical considerations of a short course radiation is very simple. We want to have a maximum dose of 25 gray to the small bowel. So it does create a problem when there's a lot of bowel in the pelvis. We're probably better off with going with a long course. And also avoiding the anal canal whenever possible. We have intensity modulated radiation that gives us more ability to spare normal tissues. In my practice, I use that for 3 reasons, whether I'm using short course or long course radiation, and that is if there's fixed small bowel, that's a problem for long-term effects of radiation causing chronic diarrhea, or fistulization. So it should be avoided, the bowel should be avoided whenever possible. Or when I'm treating the inguinal areas in female patients, because those areas can't be treated with 3D conformal treatment without treating the genitalia to a dose that would cause sexual side effects. So I'll show you examples of that, and then I'll wrap up. The third thing is that whenever there's a lymph node that the surgeon's not going to be removed, and I'm treating the patient pre-op, I have a discussion with the surgeon, and that's usually internal iliac lymph nodes. They're not always removed. Sometimes they are, sometimes they're not. But I like to know what the surgeon's going to do, because we can give a definitive dose of radiation with IMRT, and I'll show an example of that. Here's an example of a way that we would treat the inguinal lymph nodes if the tumor is involved in the anal canal, and we would expect the drainage to be at risk. And this curvature right here is something that you cannot get with 3D conformal radiation, and that spares the female genitalia. The male genitalia is easier to spare even without this technique. And then the IMRT can also give you a concave shape that will help you spare the intestine. So here's an example of an enlarged internal iliac lymph node that the surgeon may not be able to or want to remove because there are a lot of internal iliac veins around that. And so one of the things that we can do is give a higher dose just focally to that area at the same time. It's called dose painting, that we give our standard radiation dose to the rest of the pelvis. and we can increase that to a definitive dose. 63 or 70 gray instead of the normal 50 gray in 25 fractions. So that's all I have planned. Thank you very much.